Hello, my name is Sihun Han. I'm a professor of pediatrics and medicine at University of Washington School of Medicine, attending at Children's Hospital in Seattle here. I really appreciate this great opportunity to present our ongoing pilot study for Wilson disease in Washington State. I'm a member of Children's Hospital workforce, faculty at University of Washington, and founder and temporary CMO of Keyprodio, with ownership equity interest in the company. Keyprodio is a spin-off company from Children's and University of Washington. Newborn screening is considered most successful public health program in the United States since 1960. PKU, or phenylketonuria, was successfully implemented in 1960, and we were successful in changing their clinical course by early detection and management. Right side of this, the picture, child with a severe mental retardation who missed a newborn screening. Left, a baby picked up by newborn screening with a successful intubation, growing normally. So we no longer see this full brown picture of PKU patients in the clinic anymore. Untreated Wilson disease can be fatal, with many deaths attributed to liver disease and some to complication of progressive neurologic disease. Recognition, screening, and differential diagnosis of Wilson disease remain very challenging due to variability of their manifestations and lack of acceptable population screening tests yet. At present, the use of any single genetic or any test does not permit de novo diagnosis of Wilson disease. Despite greater awareness of this Wilson disease, advance in genetic testing, and improved prognosis with early diagnosis and treatment, delayed diagnosis remain quite problematic for many patients. Since the first case reported in 1902 by Dr. Wilson, similar presentation still seen in the clinic to date, without advanced liver cirrhosis or permanent brain damage. Our ultimate goal here is to change their clinical course dramatically with early detection by newborn screening. Newborn screening, the aim of newborn screening is to detect those treatable congenital conditions that can affect long-term health and the development of a child. Wilson and Eugner universal screening criteria designed to support early disease detection where adequate treatment is available and can provide it promptly. Wilson disease meets all these universal screening criteria except for having acceptable population screening method yet. Ceruloplasmin has been tested and investigated as a population screening tool in several pilot studies with, however, limited outcomes. More recently, in a proof concept and evidence study, ATP7B peptide analysis using dried blood spots, which aims to enrich and quantify peptide of interest with a very high precision from dried blood spots, was investigated as a potential screening for Wilson disease. My colleague and I conducted a very large study, samples from 216 patients with Wilson disease aged 2 months to 73 years. ATP7B levels were measured in dried blood spots from each patient using immunoSRM, or compared with the genetic and ceruloplasmin test results. Of these 216 patients, 211 had available genetic test results. Of these 211 patients, 144 had genetically confirmed Wilson disease due to being compound heterozygous or homozygous for non-pathogenic or likely pathogenic mutations. 67, however, had ambiguous genetic test results that prevented straightforward genetic diagnosis of the Wilson disease. ATP7B peptide showed in dried blood spot ATP was deficient in 131 out of 144. Those genetically confirmed the case. Hence, the ATP7B peptide analysis results agreed with the sequencing results in 91% of patients of those genetically confirmed case. And importantly, 94 patients with these ambiguous genetic test results were found to be ATP7B deficient, again highlighting the utility of ATP7B peptide analysis in this group of the patients. Of those 200 patients with available ceruloplasmin test results, 16 had a normal ceruloplasmin level defined as more than 20 milligrams per deciliter. ATP7B peptide was deficient in 14 patients, highlighting the utility of ATP7B peptide with Wilson disease with a normal ceruloplasmin value. Of all the results indicated, ATP7B analysis by immunoSRM in dry blood spots can reduce ambiguous results obtained from the ceruloplasmin and genetic analysis with a positive predictive value of 98% and negative predictive value of 91.5%. It is noteworthy that some patients with the Wilson disease may not be identified using ATP peptide analysis, resulting in false positive and false negative. In contrast, some patients may be falsely identified, resulting in false positive case, which is inevitable in newborn screening type of the assay. This is the cartoon showing our technology. I'll skip this slide. If anyone would like to learn more about this one, I'll be happy to explain later. So we developed this multiplex assay targeting 4 disease and 4 target proteins with the 6 surrogate biomarker peptides. For Wilson disease, we selected 2 peptides, as I shown before in previous slides, ATP7B887 and 1056. Selection criteria can be found in our previous manuscripts, but a main consideration is the uniqueness in the proteome. To establish this high-throughput analysis for public health transition, we have generated all reagents necessary for performance of the assay in prototype kits under the GMP manufacturing organization for FDA approval purpose. We made a mixed set of beads coupled with the 6 monoclonal antibodies here. And also we generated a live lysosomes internal standard into the place to get away from using a frozen stock. And also we made 3 different concentration of the peptides for QC purpose here. A large-scale pilot study began last year in collaboration with the Washington State Department of Health, a newborn screening laboratory targeting up to 50,000 newborn babies to screen. Samples below initial cutoffs are sequenced for confirmation or exclusion. Left shows the first sample collection in the state program, and on the right, first test run in our laboratory. To date, over 18,000 samples were analyzed. The majority of them are over 2,500 grams of birth weight collected within 3 days after birth. Their ethnicities are similar to other Western states in the country. The US, the ATP7B and the 1056, 87, and 1056 have been successfully analyzed with the tentative cutoff as shown below down here, though the cutoff is still a moving target. The peptide concentrations were not affected by their genders, female and male, similar or almost identical for 887 and 1056. ATP7B peptides were not affected by their birth weight. Average is similar even in less than 1,500 grams of the birth weight here. Average of peptide concentration was not affected by the age of sample collection, though the ranges become a little bit narrower a week after birth. Finally, the peptide concentration was not affected by their ethnicity here, from white to Native American and likely the mixed here. There was one presumptive positive case, but determined as a carrier. This variant is a synonymous variant with a very high allele frequency, 2.5% in general population. So this case was determined as a carrier. There's no physical evidence of hypomorphic the mutation for this synonymous mutation. We explored those cases with the marginally above cutoff case to see if we miss false negative cases. They were all above the current cutoff. The most recent case was an intriguing case here with the 2 variants of uncertain clinical significance. They both are extremely rare variants. The predictive program for 610 was suggestive of most likely a benign in nature, but the other one, the 1225, was probably damaging with the predictive rebel showing a 0.744. So why we presumably this is most likely a carrier, but we'll need a more further study in future. In summary, the study highlights the use of novel IVD assay demonstrating the feasibility of LC-MS/MS proteomic for MBS for Wilson disease. The performance and precisions were very excellent. Overall, the false positive rates seem very low, while false negative case cannot be entirely ruled out at this point. Of course, the large-scale prospective pilot study would be very helpful. LC-MS/MS is considered very highly specialized technology. However, it has been broadly adopted in clinical laboratories, including newborn screening. So following the standard validation process in the clinical laboratory and the newborn screening laboratory, we anticipate this assay can be successfully implemented into public health program. Many special thanks to our collaborating teams here of Washington State Newborn Screening Laboratory, Children's Hospital, University of Washington's Key Prodeo and my lab, and also the global collaborative team for Wilson disease. And also thank to a generous grant from Wilson Disease Association. Thank you very much for your attention.